So we're now going to start our public board meeting, which, partly because it's December, is not the longest of our board meetings. Not that an agenda has ever stopped us making a board meeting longer than the timetable, but I think we will keep the timetable. Do colleagues approve the minutes of the last meeting? Good. I think the only item on the action log that struck me was that we were supposed to have an update on the staff survey results at this meeting, but that's been put back to January, so that's when we're going to have it. So, David, would you like to give us your report, please?
Thank you, Michael. Good morning, everybody. I'm going to try and do 4 or 5 things in presenting this report, and I'd like to take the performance and the very brief item on the Public Accounts Committee, where I said I'd provide an oral update together rather than take them as 2 separate items. But firstly, Michael, if I could just thank you publicly and pay tribute to the way that you've stepped in to chair CQC over these past 7 months, and just thank you on behalf of the board, I think, for everything that you've done over this period. I know how much you've given to CQC over this period and how much time you've made available to me personally, but also to the responsibilities of the chair, and we're both very grateful and very appreciative of what you've done. So thank you. I'm sure I'll speak for everybody in that. Thanks also to Lewis for covering the Regulatory Governance Committee as well. I really don't underestimate how 2 busy people have got to create the time to take on additional responsibilities, and thank you to you as well, Lewis. So if I could present the performance report, attached is an annex which gives the very fine detail and reports up until October in relation to the performance of both registration, our performance again in delivering the inspection programme, and also our performance in relation to producing reports within the 50-day target. In addition to this, and following the Public Accounts Committee, a delivery progress report was circulated, I think, in advance of the meeting. And I would like to refer to both the annexes in just walking through our performance in relation to delivering the programme. You can see from the performance report, the monthly performance report, that work continues to take place in relation to our performance in registration. There are a number of issues that Andrea and her team are working on to improve our performance in registration, and we set out some of that activity in the performance report. In relation to inspection targets, as I said in the introduction, the charts in the performance report are looking at the picture as at the end of October. There are signs of improvement in performance in those figures. If you could then refer to the additional report which was circulated yesterday, the delivery plan, and you'll see on page 2 of that delivery plan there's a much more up-to-date position in relation to performance against the programme. And I think what this report is beginning to demonstrate are the improvements which are indeed taking place. I think we've used a metaphor of a petrol tanker previously beginning to turn, and I think this report is some evidence of improvements beginning to be made. There is more to do. As you can see in bold, there's some 2,500 inspections behind the programme plan, and in the table that sits below that bold statement, there's a detail of what the gap is compared with the plan, expressed as both percentage and in terms of real numbers. So the issue as we progress towards September of next year, in Mike's case April, June and December, is whether that backlog is going to be caught up. At the minute, the performance is improving, and I also know that productivity is improving across both primary medical services, where performance is increasing significantly and is above 2 now in relation to inspectors. In the north of England, I think it's above 2.8 in relation to inspections conducted in a month. And I think in Andrea's directorate it's gone up from, I think it's 1.5 to 1.7 off the top of my head. I'm sure Andrea will correct me if that's wrong. So I present this information, Michael and colleagues, on the basis that there are improvements taking place. Again, on the performance reports, if we look at the inspection final reports, I think what the evidence is in relation to the October figures, and again in the November figures, is a continuing improvement in the number of reports which are produced within 50 days. And I think there's a steady trajectory is emergent, and I think the bar charts on page 7 begin to set out the detail of some of that progress. If I could come back to the delivery plan update, this is in relation to the Public Accounts Committee. I think what we've done on slide 3 is set out a pretty high level, and there's detail that sits behind this, is the 2 themes, if you wish, which are an essential part of this delivery plan. Firstly, there's the work which is to undertake improvements in productivity in each of the directorate, and I think the improvements have been made through improved management information which goes down to practice manager level, inspection manager level. Heads of inspection developing much more specific plans of delivery for their areas, an improvement in the way that inspections are scheduled. There have been capability issues which have been raised with individual members of staff in relation to whether their performance and productivity is satisfactory, and where that's identified as an issue, people are offered support, and in 1 or 2 cases that's led to people not continuing their employment with CQC. Work has been undertaken to remove unnecessary tasks or steps in the processes that we've got for clearing and agreeing reports, and there's been work to improve the support that enabling directorates, this would be things like business support, are able to offer to inspectors, inspection managers and heads of inspection to allow them to focus on delivering the programme. So I think we've improved our productivity, and we've calculated that to be about 1,400 inspections over trajectories from the low point at the beginning of the year. And I think this is reflected in my comments about improvement. The second area, second theme that's behind this delivery plan are the way that we've used the resource that we've got available during this current financial year, financial resources, to pay overtime to inspectors where that's appropriate. We've tried to be cautious about this because one of the issues is not getting an expectation that people work too hard. Again, I think the theme at our last meeting was attempting to strike a balance between the work that we're asking people to do and the number of people that we've got available, but also using bank inspectors to support the delivery of the inspection programme. And again, we've set out in this report our calculation about the number of additional inspections that we've been able to deliver using overtime payments and an increased use of bank inspectors. Lastly, on the delivery programme, we're reflecting on the work which is being undertaken for the remainder of this year to plan the work for next year. The significance of this is that the delivery of the programme was always scheduled to be completed in the financial year 16-17, and therefore we'll continue to monitor and assess this. It has to be said the programme continues to be at risk with 2,500 inspections adrift, and one of the issues that we need to address as part of the planning over the next few weeks is whether it's possible to catch up those additional inspections. The other thing that we can't be confident on is how many inspections we'll do between now and September, which will require repeat inspections, and they will need to be factored in. So in December and January, the executive team will consider the continuation of the programme and the planning for next year, and that will be brought back to this board in January of next year. So, Mike, well, if I just say one more thing about the Public Accounts Committee. The process following a Public Accounts Committee is that the Department of Health writes to the Treasury, right back to the Public Accounts Committee in a process that's laid out by the Treasury, where they've got to do that within a 6-week period. They will consult with us, but it's their responsibility to write to the Public Accounts Committee, not CQC's responsibility. We will inform that response, and some of the things that I've just shared with the board will inform that response. In addition, we were asked in the report that they published to write directly to the Public Accounts Committee in July of next year, outlining our progress in relation to recruitment of inspectors and in terms of delivering the programme, which we will do, and the work that I've just outlined will inform that. In addition, the National Audit Office, when they produced their report, presented the report to CQC. They did that at the Audit and Corporate Governance Committee. There is an action plan against each of their recommendations, and Paul and the Audit Committee continue to oversee that. I think one of the things that we'll need to do is bring together the actions under the Public Accounts Committee report and the NAO report. I don't think we should be running two separate responses into one. It's our intelligence, following discussions with the National Audit Office yesterday, that they will be looking to return to continue the second part of their work at the end of the second quarter of the next financial year. They're likely to begin the field work in late spring, early summer, up to the period of September, October, with a view to reporting again in January, February time, maybe December, January, February next year, with a further Public Accounts Committee hearing, in their view. It's a decision for the Public Accounts Committee, but in the view of the NAO, probably in February of next year. So I think the milestones in terms of accounting to Parliament are going to be in July with a further letter, a further period of fieldwork from the National Audit Office, which will take place during the second and third quarters of 16-17, with a report any time from November from the National Audit Office, and a further Public Accounts Committee in February of 2017. Their plans, those plans can change, but that's what's set out at the present time. So if I pause there, Michael, I think the substance of this is the performance report and the progress against the report, and the further information which we produce as a result of the Public Accounts Committee, which we're calling the delivery plan, the delivery programme. That's how we will continue to refer to this piece of work. Pause.
Any questions for David?
Just two questions about the performance report. Just in relation to as it were, the backlog of registration applications, could I ask what we consider the risks to service users and indeed the system in relation to that, and how do we mitigate that? And the second in relation to delays in inspection reports. Have we considered, or should we be considering, whether the gap, where there is a gap, can be filled by any form of interim report, understanding that, of course, more reports produce more work. But I just wonder whether, if one has got to the stage of actually knowing what it is we're going to say, we can't at least publish some headlines so that users, the public, actually know a little bit more about what we know sooner than they do at the moment.
Apologies, I pressed the wrong button. So on registration, what we've done in the report for today is to show you the breakdown between cancellations, new registrations and variations. And what that demonstrates, I think, is that it's the new registrations that are our significant problem area. And what the graph above indicates is also that the significant problem is where we haven't actually specified which of the three sectors it sits in. And what this is telling us is that it's those kind of new models of care, different ways of doing things that are providing us with a bit of a challenge. And this is about completed registrations. So the process we'll be going through, and one of the issues for us is that the completed registrations are counted even if that's a decision not to register, and that's been appealed against, and there's been a process gone through for that, which obviously will take us beyond the 50 days. And a separate conversation that we've had is about trying to make sure that we can separate that out and actually really focus on those areas that we need to be looking at. So just to give you a little bit more context to the figures, to answer the question about risk. The risk should not be that high, because basically new registrations, it will be a new service that's coming into being. They won't be operating it until actually we've provided that registration, if it's a completely brand new service. So there may well be an issue of how long it takes to establish that, but normally we're working with providers well in advance of their plans to actually open services up. So that shouldn't have an impact there. Where it's a new registration because ownership is transferring as organisations either sell their services or ownership moves between because of whatever different reason, the existing registration will be maintained until until the new registration is in place. If the final thing to say is, if there are significant issues of risk and concern that are raised with us, either by people who are using services or by commissioners, for example, or providers, and then obviously the teams are looking at that in terms of where they should prioritise their work in responding to that level of risk. So there's a variety of different things that the teams will be taking on to do that.
Could I just supplementary? Is there are there cases where actually there is really no problem at all, and is it where a perfectly respectable, efficient, useful business is being prevented from getting going, and thereby depriving the public, which we ought to be perhaps spending less time on than we may do? I don't know. I just asked.
So this is one of the things that we've set out in the in building on strong foundations, in terms of the potential for us looking at registration in the future in a much more kind of risk-based way, so that if we have if the kind of new information that we've got ahead of the consideration of the registration application gives us that confidence, then we can move forward in a faster and a different way, and that's going to be part of the consultation communication again that we put out in January. So it is something that we're looking at and considering, Robert. The other issue, I think, where there is risk is where we have people who are unregistered and not applying to register, and we may not even know about those services. So that's the flip side of the coin, if you like, and making sure that we're getting intelligence and insight from people about those risks so that we can actually address that either by getting those services to register or by taking action against them, which we have done over the last year.
I think Mike, perhaps, on inspection reports.
Yes, if I just sort of remind people what the various steps are, but then there's a very legitimate question you just asked. First of all, we do always provide immediate feedback to the Trust at the end of an inspection, and what we've heard from trusts themselves is that they want more rather than less immediate feedback. They prefer to hear all the bad news, if you like, if there is bad news, and so they can be getting on with it. What we have recently started doing, well, we did it in occasional cases before, but we're now doing it routinely, is to write a letter to the Trust effectively summarising what we said in that verbal feedback. The letter has to have caveats on it because obviously we haven't fully assimilated all the evidence that we've collected. And there may be things that we realise that we should have mentioned at the immediate feedback, and we take that opportunity then to include that in the letter. We're not currently publishing those letters, and I think that's something that we would need to take away and think about. We do, of course, where there are real concerns about a trust, we do take enforcement action, and in some recent cases, for example, we've issued warning notices, Section 29A warning notices, that, again, we don't make that public until the time that when they've had an opportunity to make representation, so that isn't immediately in the public domain. The other bit of major work that we are doing is looking at how we can make our reports a whole lot shorter and clearer, while at the same time collecting all the evidence and making sure we've got all that. And there's active work going on that at the moment. But I think the question is whether the letter to the Trust should or should not be published. And
David.
Sorry, I think in addition to that, on adult social care and primary medical services, I think the effort is going into getting them out within the 50 days rather than sending out an additional one, and I think that's the key challenge. I think we should get it right and get them out, quite frankly. I think that's where our focus should be, is streamlining it and getting the reports out, rather than sending additional reports out.
Emma.
Thanks very much. So, I think it's great to see in the delivery programme that you've managed to squeeze, if you like, out of the approach a number of productivity gains, and that looks like a not insignificant increase in numbers, which is really good. So just to sort of acknowledge that and say thanks to the team for what I'm sure was a lot of work to make that happen. But makes me want to ask the question, what you've learned as a result of that process about whether there is more room to improve productivity in these and or other areas, because and I'm asking that question partly because we know that there's going to be increasing pressure on resources going forward, and so there's only going to be a need for more of this kind of productivity gain. So I'm just wondering if you could say something about what more room you think there might be, and what you've learnt from this about how you could improve things going forward.
So is there more room? Yes, there is. And I think I outlined some of the things in presenting it, and it's in that additional paper that came round. There's more that can be done in relation to how we can work smarter, how we can work more efficiently, how we can take process out, how we can delay that, how we can ensure we get it right first time and not have to have a sequence of quality checks built in, all of which contribute delays. So I think we are at the beginning of that process, and not at the end of it. I'm absolutely clear that people right through the organisation are working very, very hard to do that, and there's work in place to do this. Just as an aside, I was finishing off some things on Friday afternoon and out walked one of Andrea's teams from the South East that had spent all afternoon scheduling their work for the remainder of the year, and the first thing they said was, we're confident we're going to get there or thereabouts at the end of this, and we're working very hard to deliver it. I then said hello to them. So I think that gives you a sense of where people are in terms of their energy and the way they're engaging this. I think what I've learned from this is that we need to constantly attend to the issue of balancing what we're asking staff to do and the expectations and the systems and processes that we build. And there's that kind of classic, you build this as you would ideally want it to be delivered, and then you actually realise that actually the reality of delivering it to the standard that it's been built is really, really challenging and at times impossible and difficult. And I think there's a seminal lesson in there about how do you design something to be lean from the beginning. We were where we were in 2013-14. We've got to move quickly. We've got to deliver new ways of operating. And in an ideal world, you would have taken longer. You'd have built it. You'd have tested it. You'd have refined it. You'd have tested it again. You'd have gone out and done it. And that isn't the reality of where we were. I'm under no doubts about that. For whatever the Public Accounts Committee have said, I do think we were in special measures in 2012 and we needed to get out of it, and we weren't going to be able to negotiate a 3, 4, 5 year period to get out of it. We needed to move quickly. I think that is a political reality. I think that's what we've done. My disappointment at the Public Accounts Committee is the work that has been undertaken wasn't acknowledged. I think people have worked phenomenally hard to actually change the way we've done it. We've had a discussion here about the language we use about that. We shouldn't make any claims that we've transformed anything, but we have changed things quite dramatically from what we've done, and I think that's absolutely right that we should do that. And so, Anna, in response to your question, we've never been in an ideal world, but how we build that and constantly delayer that. I think the other thing I've learned is we need to be much more open and inclusive throughout the organisation about how this is going to be done. I think every manager and every member of staff through the organisation, as we go through this next 4-year period, I mean, the last paragraph in my report this morning is just saying where we are in relation to the financial position. I think it is now clear that we will take a 25% reduction in our grants in aid from the Department of Health over the 4 years to 2019-20. What that means is that our budget for 19-20 will be £217 million. And I think that just reinforces why we need to continue right through the organisation to accept that's where we are and continue to work towards ensuring we can deliver the regulation of health and social care in England by 2019-20 within a financial envelope of £217 million, which is £32 million less than we've got now, and that's the reality, and that's what we'll do. I think people out there don't understand that we are taking a reduction of 32 million over that period of time, and we need to work within that. So I don't. It's not an option that we don't work to become more efficient. And as I sit here this morning, it's not been the best couple of weeks in my existence as chief executive of this organisation, but I'm absolutely confident we can do that, and that's what we're focused on, and that's what we'll do, and we'll bring that back in January to the board with a business plan that's beginning to set that out, and I hope that gives you some of the learning.
Paul and then Jennifer.
Thanks. Building on David's answer to your question, Anna, a lot of the work that's gone on to improve productivity has been about bringing in enough inspectors and registration inspectors that the caseload can be shared on the data raising of concerns more appropriately, so that staff aren't only doing that, and they're able to do more inspections as well. There's also been a lot about setting expectations clearly of the number of inspections that are required and the quality which they're required. We know we've still got variation in that, but that's something that's been communicated clearly through. The bit, as David says, that we've spent less time on as we built up the model is getting our systems and processes right so that it becomes simple and easy to do the right thing. We touched on some of this at Regulatory Governance Committee yesterday afternoon, but it's important to link that through to the productivity rather than being something that's happening to the side. The act, as Mike said, of being clear about what needs to be in a report and what doesn't, and therefore what evidence can be collected and collected easily and how we pre-populate that evidence from the intelligence that we have, both makes inspectors' lives easier, it makes quality assurance quicker and easier all steps, and it means that reports can come out a lot faster. So we're expecting the next sort of change in productivity to at least in part come from better systems and processes and better implementation of the operating model. And we'll discuss the strategy in the private board session, but absolutely the heart of the strategy is getting us to be more of an efficient and effective regulator so that we can live within our means, as David says.
Thanks. The trajectory of our inspections, the run rate, if you like, is going to be sensitive to quite a few assumptions. So I think when we come back in January, could we codify those and set them out to see? I mean, I'm just thinking if we do have to do a whole lot more of re-inspections or enforcements and stuff like that, it's going to be quite sensitive to the target date, isn't it? So if those could be set out and we can chew on them a bit.
Paul. Lewis, sorry.
So this is not about performance, it's about the report in general. There's a couple of things. First of all, could I just ask you to clarify how and when we'll talk about the Southern Health report that came out a few days ago? This, to remind everyone, this has followed the death of Connor's Sparrowhawk, an event, tragic event, that we've had quite a strong interest in this board. It's complicated by the fact that the report is not actually published yet, although we are told it's imminent. So I understand why we're not talking about it fully today. But once it is published, I think we will have to return to it, I believe, in public board session and at the first meeting following its publication. So I'm just looking for a sort of reassurance that that will be the case. Bearing in mind that of course, it's a very important report because it's about how decisions are made on how to investigate or when to investigate the deaths of people who are under mental health and learning disability services. And the implication is that those decisions are not always made in the right way, particularly in relation to learning disability, and therefore there's a lack of learning about prevention of deaths. And then it is also about the involvement of families after a death. I suppose before a death as well, but after death. So these are two very important issues to us. Apart from discussing the report itself, the implications nationally, because we don't know that this problem applies only to this trust, and the implications for how CQC conducts its work, I think could be very important. I think it's a very, very important case for us. So I'm just looking for an assurance that we'll return to it at the right time, the earliest time, and in public session.
I'm just happy to give that assurance, Lewis. As you've rightfully said, it's a report which was leaked, and therefore I think it's not completed yet. As I understand what's been in the media, work is to hand to complete it. A number of us have considered that leaked report and some of its implications, and I think you've pulled out those that are those questions which are raised through that report. I'll be very happy to bring back a report to the January meeting which actually goes through this, and we'll bring that back in open session, and we can lay out our reflections on the final report, and as you've filleted those issues, what it says about the numbers, is this something that's happened elsewhere, how are families engaged, what are the implications for CQC, and we can lay that out in a written report to the public board meeting.
Yes.
Sorry to come back. This is on a related but slightly different point. Just briefly, if I could just remind everyone that we've had two reports which are sort of essentially about mental health published since we last met. One was our Mental Health Act report, which, amongst other things, reported that there had been 227 deaths of people while detained under the Mental Health Act in the previous year. That's a fairly typical number, in fact. Most of those deaths are people who are older people dying of natural causes, but not all. And even when they are the deaths of older people dying of natural causes, that doesn't mean that there weren't elements of prevention that could have been stronger. This issue of it's an equivalent issue in a way to Southern Health. There's an issue of how and by whom these deaths are investigated. And I would just say that we've probably talked about this a couple of times at this board, and it is problematic because the responsibility for Mental Health Act matters is shared. Different responsibilities lie in different places. But I just hope that over the next few months that we'll get to the point where, because of pressure from other groups, deaths in custody committees and so on, we'll get to the point where we're a little bit clearer on how these deaths are investigated, who should do it, and what happens to the information that investigations produce. Because otherwise we're in danger of having this as a report which sort of comes out relatively quietly, but is actually dealing with one of the most important things in the entire NHS, which is people who die while deprived of their liberty under our care. And if I can just for 1 second just refer to the other report, which is the deprivation of liberty safeguards, so in some ways a related issue, which also came out. And the headline message of this report is very, very important people realise this, that following a decision by the Supreme Court about the eligibility for assessment under deprivation of liberty safeguards, the number of assessments, the number of applications for assessment nationally went up from 13,000 to 137,000. And as a result, the system is in a state of collapse and chaos, as you would be if you had a tenfold increase in activity overnight. Therefore, there is a 56,000 case backlog of assessments. It's an absolutely extraordinary state of affairs, which I don't suppose the Supreme Court had in mind when it made that decision. It's just the law of unintended consequence, which is, of course, the one law that no government can ever change. I just would like us to note that and to lend our support to what I hope will be measures through the Law Society and others to try and correct what's become a system in chaos.
Before you do, David, would you mind if I just added one thing? Because I just want to furiously agree, but say in relation to the discussion about the investigation of deaths, that there is there are a variety of cases, but there were 3 deaths at St Andrews, which we have talked about here before, and which the local health watch in Nottingham have been very engaged in talking with, in particular, NHSE about the investigation and reporting of that investigation around those deaths. And it's a classic case, it seems to me. It's taken years. I actually have to confess I'm not quite sure whether it's even yet been published, though we have been promised it and promised it and promised it, and it has. But what we do know about it is that it doesn't ultimately meet the needs of those people who needed to have the investigation done, the friends and family of those who died. So I just think that might be something quite helpful in having that discussion at the board with at least a case study or 2 of what's happened and how it's happened, because it really does expose the difficulties of getting a kind of clear line of sight about responsibilities and managing expectations of the public who are directly involved.
David, anything more on your report?
Michael, there are just a couple of things. Lewis has raised a question of Southern, which I was going to cover in comments, and I'm grateful for him raising that. I would like just to draw attention to paragraphs 5, where Andrea and her team are carrying out work in relation to enforcement, but also Operation Magnify, which is the focus on illegal workers in the care industry, where we've been undertaking joint work. Interestingly, in terms of the discussion about how many care beds exist in England at Annex 2. There's an analysis which has been produced by Paul's colleagues, the analyst, which is showing that at a national level, in 2010 there were 460,000 care beds in England, and in 2015 there's 464,000. It is a 1% increase. Within that, you've had a reduction in care homes, an increase in nursing homes. That doesn't say these are all operating. It doesn't say they're all full. But in the debate about how many places are around, it's an interesting contribution to that discussion. And of course, if a care home closes in a particular area which is dependent on that care home, then the impact locally could be quite significant. But important information. Steve's updating on out of hours and dental, and Mike is showing the most recent inspection reports that are produced. Last thing I wanted to draw attention to, Michael, is in light of the Paris and events in Belgium, government have issued advice on staying safe. We've issued that within the department. We've got over 400 people that come to work in London, and the issue about people being safe in London is a key issue. Not just London, I think, but is a key issue. So we've already run what's called a Silver Command exercise, which is a desktop, and Gold Command is where colleagues in the executive team are engaged, and we'll look to be doing that in January. So this isn't do we have procedures, it's have we tried these procedures, and do we all know what it is that we need to do if this is something which we're called on to put in place. We recently had a fire alarm test in this building, and it was clear that people didn't know where to go. So actually testing this is a key issue. I can see people shaking their head. People didn't know where to go because this is the first time we've run a fire alarm in this building, which we've been in for just a few weeks. But this is a significant issue that we need to test, and I just wanted to, I thought it was worth just drawing out to members of the board. So with that, Michael, I think I've covered all the things that I needed to cover. Thanks very much.
Thank you, David. We now move to the next item on our agenda, which is a report on the RGC committee meeting that was held yesterday, and I think colleagues have in front of them a description of the meeting. Lewis, would you like to take us through this, please?
Yes. So first of all, thanks to Martin for doing what he usually does, which is preparing overnight a summary of last night's meeting. So it's a short summary, and a fuller summary will come to the next board. I'm going to focus on the first of... There were two items mainly at yesterday's meeting, and I'm going to focus on the first one because this followed an inspection, a care home inspection that I went on as an observer in my board member capacity, and it raised a number of issues which the board, I think, needs to be aware of. I raised these with you, Michael, and you suggested that they be discussed in full at the RGC, and then we would be able to have a sort of more concise discussion at the full board meeting. So that's what I'm going to do. I'm just going to report on some of a summary of the issues that came out of this, and then ask Andrea if she'd comment in board session. So this is a care home, and it was a routine inspection, and essentially it was a care home in a terrible state, and it was, in my opinion, it was unsafe for a variety of reasons, but one in particular was that a resident had fallen down a fire escape just a few days before, having wandered during the night and been able to open a fire door, which since that incident hadn't been properly repaired, although some restrictions on the movement of the resident had been introduced. And so I was we collectively, the inspectors, I must say, were very professional, I was very impressed by them. They were very concerned about safety, they were very concerned about the about fire safety as well. And there was a strong concern about hygiene and infection and the general insanitary state of the care home. It was badly stained in lots of places, including what we appeared to be fecal staining on the walls. And it was so full of ingrained stains and cobwebs, it really looked like it hadn't been cleaned for months. So it was a terrible state for residents to be living in. When we left the care home, well, we all felt very uneasy about the fact that we were leaving, going home, but the residents were staying there, and so there was a discussion about whether immediate action should be taken to close the care home, but because of the disruption that would cause, there had to be a judgment made about the balance of risk that closure or non-closure would entail, and a decision was made, which I completely understood, not to immediately close the care home. And so what this raised for me was what we do if we don't immediately close a care home. What's the appropriate level of urgency of action that we can initiate when we don't immediately close a place? And I ask that partly because we're quite dependent on other agencies, particularly in the local authority, if we are taking urgent action. And they may not pick up the urgency because they haven't been on the inspection. So the first question is, what urgent action can we take? And how does that work? How can we be certain we're responding with an appropriate level of urgency? The second issue was that the owner of there was a sort of odd history to the ownership of this care home, which involved an application for ownership by a GP who had in fact been struck off for dishonesty. And he was not allowed to be the owner, but another member of his family was the owner, and so the registered owner. And that allowed, we were told, his continuing involvement in the day-to-day running of the place, even though he wasn't the registered owner, and it was thought to be unsuitable. Now this, for me, is a very important question because it also feeds into the broader issue of the manoeuvres that can be taken by providers to avoid being prevented from registering. Changes of names, just ahead of the head of the posse, so to speak, ahead of the report, in a way that's misleading to the public and runs the risk of perpetuating poor care because proper action then isn't taken because it's a new organisation under a new named owner or a new name of provider. So there is a broader question behind that concern. Thirdly, there was the rather unnerving point that when we asked the residents what they thought of this care home, they thought it was okay, and they did have some concerns, but they certainly didn't have concerns of the kind that we had. As far as we could tell, there weren't concerns from the relatives either, from families, that reflected how seriously we took the situation. So I feel strongly that it ought to be part of our way of practicing, that we inform residents and relatives of the outcome of an inspection. Now, there are already requirements placed on providers to go some way to doing that, about displaying ratings and that sort of thing, putting it on their website. But, some relatives live some distance away. They may not call in often enough. The prominence of any rating on a notice board is sometimes not very great. I think we should be writing to relatives to tell them what the judgment has been. That's a debate we need to have. But I think we can't simply rely on providers who have shown themselves. Bear in mind, they might be telling them something good, so that's one thing. But I think also that we can't rely, when they have been responsible for very poor care, we can't rely on them to pass on that information to the relatives who are paying for the residency. And finally, just quickly, there was a final issue which wasn't specific to this care home, which was about, it's relevant to the performance discussion we've just had, because it was about the delays that inspectors report in the completion of reports, having completed an inspection. So the issue here is that sometimes when they produce a report, the extent of challenge from a provider is so great that it takes far longer to respond to the challenge than it did to do the original report. For example, these inspectors told me of I may get the numbers wrong here, but you'll get the general idea, that they wrote a 30-page report on a particular care home inspection. The provider challenged every point in that inspection, and that challenge was something like 70 pages long, so about twice as long as the actual report. And then the inspectors had to reply, so they produced a reply which was over 100 pages long, so 3 times longer than the original report, and took them something like 11 days to complete it, which meant that the next inspection they had to carry out at the next care home had to be postponed. So I just think that we need to have that in mind. This is what's happening out there in the field, the games that providers can play to put us off, to make us a little less bold about what we're prepared to say in case we have to start justifying it legally in some sense. And I'm afraid what I'm absolutely certain is vexatious challenge. I think we have to, at the very least, the public, residents and families need to be aware that that's what providers do. But also I think we need to be looking at what measures we can take to reduce this problem. Thanks, Mike.
Thank you, Lewis. I think this actually, but before asking Andrea to respond, illustrates a few points. One is that I think these visits or shadowing inspections by NEDs is very important, because I think it gives an insight into the CQC, which would be is very difficult to capture just on paper. The second point, and I think Lewis has described this very well, although this was about an individual case, it actually gives rise to a series of issues which go far beyond the particular care home that on which Lewis was the observer of the inspection. And the third point is, one of the reasons the RGC was set up is because it would be very difficult for this board to spend effectively the 90 minutes that we spent yesterday. So it is a vehicle for us to look at particular issues in detail, which the main board would, I think, struggle with. Andrea.
Which is obviously a good hint to make sure that I'm succinct in my response, which I will take, Michael. So just to first of all say, as Michael has just said, the importance of non-executive directors kind of getting involved in this, and actually then bringing that independent perspective back into CQC and to those of us in operational with operational responsibilities. So I'm very grateful to Lewis for the time and effort that he's put into this, and it's been really helpful. I'd just like to give the board some assurance about what's happening in that particular care home. We know that we've had feedback now from the fire safety officer that the fire safety issues have been addressed, and we also know that environmental health followed up directly with the home, although we don't have the output of that. But what we also know is that there are squads of cleaners and decorators in there sorting out the environment. So there is change that is happening in that specific home, and we'll obviously follow through with the report and any further action, and keep Lewis and colleagues up to date. But to pick on the 4 key issues that Lewis identified, and I won't go into the level of detail that we discussed last night, but on registration, I think that there is an important issue, and which we touched upon earlier in terms of the risk assessed with associated with assessing registration applications, and it's very important that we kind of make sure that we use the information at the point of registration and make decisions at that stage, and indeed did when this was very first registered some considerable time ago, and about two organisations, two regimes ago, and restrictions were put in place. But it is something that we need to be mindful of. I'm absolutely aware, as Lewis highlights, that there are some good reasons why people will change registration, and we need to, as David particularly reminded us at the committee last night, not automatically think that everybody is out to play the system, but clearly there are some examples where people are changing either their registration or the way that they're delivering services in a way that actually would cause us concern around what that means with the history of that service and what that means about the ownership and ability for them to either deliver or sustain good quality care. And there's a number of things that we're looking at, part of registration improvement project, but also in terms of how we present information to the public and the website, so it's not as difficult as it currently is to see what the history is of the service on that site, as an example. And that's something which is an issue that's been raised with me by others, and not just as a consequence of this. The second issue in terms of notice to families, 2 points to say there. One is the sad reflection that Lewis brought to us, which is that very often people do have low expectations of the service that they are receiving, and their relatives may well have low expectations, and this is absolutely the reason why CQC has to act on behalf of people who are using services, because sometimes they don't have the voice to call out the poor care or the problems that exist, and we need to be able to do that. The issue about informing, what we agreed last night was, yes, we do have measures in place currently. We expect the provider to share the summary of the report with relatives and with residents. We also, there is a legal requirement now for them to display their ratings on the website and in the service. But we will look at what more we can do to follow that up, and we'll report back on that. In terms of dealing with failure, and Lewis is right, our inspectors do an incredibly difficult job and sometimes have to make very difficult decisions balancing the risk to people at the point of identifying very poor care, because there is a risk in closing services down and moving them and doing that very quickly. And but we support inspectors in making those decisions with a very clear decision tree that actually sets a level of criteria against which urgent action needs to be assessed. But we are concerned about some of our ability to kind of manage this, both in the practical sense of what happens if we do have to urgently close a service, but also what are the other options that are available to us. And as colleagues may remember, I undertook, following the closure of the Old Village School, which happened in February, which I think we discussed at the board meeting in September, to follow up with others in the system to see what we could do about that. And we have a meeting that's scheduled for the beginning of February with NHS England, with the Association of Directors of Adult Social Services, with providers, with people who are speaking on behalf of people using services, Action on Elder Abuse, and others, to explore both the practical things that we can do better, but also what some of the other changes we may need to either ask for in terms of regulatory changes or changes to our practice. And I can report back to the board subsequent to that meeting, and I'm very grateful to Ruth Holt at NHS England and others for their help in all of that. And last but not least, the issue about challenge, and we are seeing some increase in the challenge that we're getting in a variety of different ways, and Lewis has given one example of that, which is around factual accuracy, but there are others. And I think We are in discussion with Rebecca and her colleagues about what we can do to be absolutely clear and explicit about what challenge is appropriate around factual accuracy, how we can manage that appropriately, so that providers can have legitimate challenge. I mean, it's entirely right and proper that as a public body we are open to that challenge, but equally that we do that in a way that does not undermine the confidence that the public can have in the way that we do our job, which I think is really important. And that's the last point I would want to end on, which is really to answer Lewis's concern that the challenge may cause us to be more cautious about what we do and how we do it. And I just remind board colleagues that one of our 4 key values for this organisation is integrity, doing the right thing. And in the work that we did to develop those 4 values that we've got and that we wear around our necks, if we'd taken a vote, integrity would have won by a country mile. And you can see in the staff survey the commitment that our staff have to doing the right thing on behalf of people using services. So I am confident that people will do the right thing, but we also need to make sure that they get support from all of the rest of us within the organisation to enable them to do that.
Thank you, Andrea. I hope board members are satisfied with the, Lewis's excellent report and Andrea's response. I say it's really one of the reasons why the RGC is so important. If we can now go on to the last item that we have this morning, which is essentially a review of the important work that's been done by Healthwatch over the last, effectively over the last reported quarter. And Jane is going to give us, and I wonder if you can. Oh, you think Anna's going to give it? Okay. Sorry, slightly confused about who was going to give us the report. Well, Anna, if you could just take us through the report, please.
Well, I'm very happy to take people. Thank you. I'm very happy to take people through the report, but what I would normally do is work on the basis that people have read it and just take any questions. So rather than walk through it, Michael, there's a variety of bits of information in here. I'd be happy to elaborate on any of them.
Good. Are there any questions for Anna? Robert?
I was interested in the, and somewhat depressed, frankly, by what was said in your report about funding. I'm not depressed at the fact you've said it, but the fact it's there. And I think, personally, I have particular concern about the proposition that the reductions in allocation of funding to local health watches seems to be in areas which we are likely to have the most concern about. And whereas one would have hoped it might be the opposite, because the need for health watch in such areas must be greater. And I wondered what either Health Watch, your organisation, can do, or what we ought to be doing, if anything, about that, bearing in mind that some of us at least have been dissatisfied about the way in which funding in that sector has been organised.
Yeah, so I mean, I think it's an interesting and but then perhaps not surprising fact, because Local Health Watch is funded, as I know you all know, by the local authority, and in areas where there are particularly significant pressures on the local health and care economy, it is likely, therefore, that the funding available for Local Health Watch is also going to be under pressure. And yet, as you say, the challenges in those environments are often the greatest. So two things, two sort of responses to your question. I mean, there is nothing that we can do about that at Healthwatch England in the sense of actually remedying it. There is nothing that anyone at national level can do about it, given the current settlement, which is that those decisions about funding are made by local authorities. What we have done throughout the period, throughout the last 3 years since Local Health Watch were first commissioned, is reported on the levels of funding of Local Health Watch. So made it transparent, but worked very closely with Local Health Watch where they have come under particular budgetary pressures. So some of them have experienced quite significant budget cuts in the 3-year period, and we do quite a lot of work with those that ask for it to support them through that process, and with some success. So there's help that Health Watch England can offer to Local Health Watch in their local negotiations. What we have also done in this year was to use the power that we have in the legislation to write to the leaders of to the leader of a council, and I wrote to 10 local authorities raising particular concerns about the level of cut that that 10 Local Health Watch have experienced, so in excess of 25%. In the case of those 10, asking only the question, and this is all that we can do, asking the question whether they could be confident that Local Health Watch would still be able to deliver on its statutory duties, and how they plan to monitor that in the period over which this funding had been given. We had a variety of responses, some of which were quite illuminating, some of which actually made it clear that some local authorities didn't understand what the statutory functions of Local Health Watch were, certainly not at the level at which we got a response, although I'm sure the commissioners at a working level understand. So there's a job of work to be done with commissioners and local authorities. So what you'll also see in this report is some work that we've just started doing, which is to work with commissioners directly. So until this year, the commissioners of Local Health Watch have been supported by the LGA with some funds that were given from government to the LGA for that purpose, but that work has ceased. And although Health Watch England haven't been given the equivalent funding because of these issues, we felt it was really important to continue to work with commissioners. And so we had the first gathering of commissioners and Local Health Watch. And that, part of that is about giving some exposure to commissioners about some of the good practice that exists and some of the good relationships that exist between commissioners and Local Health Watch, and some education, to be honest, about the statutory functions of Local Health Watch. So this is all about hearts and minds, and that is all we can do. What we've also, of course, done is kept the department and ministers very much aware of of these pressures, and the way in which funding is changing. So what could CQC do? I guess put its own weight perhaps a bit behind some of that discussion, and express concern. But I think that is the sum total of what we're able to do in the current situation.
One of the things that struck me looking at the figures, which I did actually do, was the extraordinary range of funding, and I appreciate that must be a lot to do with the size of the patch. But actually, in terms of the actual overall figures in each case, we're talking about what I would have thought was relatively small sums of money for most local authorities, but I know all money is important. But I just wondered whether there was some form of disparity through the country, as it were, in terms of how these things are organised, because frankly I would have thought you can do much more with £500,000 in a big area than you can with 100,000 in a smaller area. And I just wonder whether the whole thing has got too piecemeal to be, whether that someone needs to look at that.
Well, I think that's a really important question for the future, and certainly a question that we've started to sort of discuss a little with Local Health Watch. So, let's take Manchester, for example. So the 10 Local Health Watch working in the Devo Mank project are working much more closely together than many Local Health Watch are working together, because it's in the interests of their populations for them to be working with that project to get the best possible outcomes for all their communities. And I think they are pretty clear that that experience is telling them that over time, as the shape of health and care services changes, so the commissioning arrangements for Local Health Watch will probably change. And I think they fully anticipate that at the end of this process, there may not be 10 Local Health Watch, or there may be 10 organisations with a base in 10 different communities, but a different way of supporting that at what might be more of a sub-regional level. And I think, you know, Local Health Watch are beginning to think and talk about that. They're doing a number of other things in this respect. Some of them have from the very beginning been sharing costs by procuring things together. So there's a South East London group of Local Health Watch who who procure a lot of their back office services together. There are 2 instances now where Local Health Watch have a bid for the contract when it's come up of another Local Health Watch. So they are, if you like, delivering in a number of areas, still with a route in the in each of the communities, but managing them together to operate more efficiently. So there are a whole host of these things happening, and it's very much in the committee's mind at Health Watch England to have more of that kind of discussion with Local Health Watch during the course of the next year and support them in whatever ways it seems appropriate to support them to bring about sensible change. So, yeah, very much the issue.
Thanks. I just had a quick point about primary care. I thought the People's Experiences of Primary Care report was a really good one. 11,000 people talked to about primary care, and it shows high levels of satisfaction with primary care, which is fantastic considering the strain primary care is under. Access is the biggest thing by far that came out, and it's just a question for Steve for him to reflect on our model for inspections of primary care and the extent to which we're getting under the skin of access issues, given that a lot of our inspections are about the quality of care once people are in the system.
That's a very good question, and it comes back from when we're talking to patients as well, and links into access during the week, out of hours, 7-day working. And we've been having some discussions with NHS England as well about how we look at access in the responsive part of what we do. Many surgeries still close for an afternoon, and many of the poor surgeries we find patients have greater problems getting hold of a GP during the day. The majority are good, and I think as we move the model forward, I think we've got to refine how we both look at access, not just in the face-to-face consultation, but the different ways of accessing GPs. Many of the outstanding practices now are looking at Skype consultations. They have extended hours and access directly to the multi-professional team. So I think part of when we take the model forward, we need to be much better at doing that and leading that into the future ratings. It's very important.
Yeah, just to say, I mean, obviously the move to have more online bookings is important, but it could also clog up the appointment system with people who may be worried well. So access to those who may need it more could be part of our interest.
Thanks. And we know that younger people, young adults, find it frustrating, and the older you are, it seems to be easier. There's all sorts of things about the demographic, and so those are exactly the sort of things we need to look at. You're absolutely right, and linked into continuity of care as well. So that's part of the thing we're looking at as part of responsive. Thanks.
I'm very glad you thought it was a good report, and I just would say, I mean, if people haven't read it, I think it's a really good description of what Health Watch is able to do now. So it has some really important material in it, but actually it has it just shows how the network has matured and the quality of the work that it's doing. So I went to the Select Committee last week their investigation to the future of primary care, and I was able to speak from that evidence. So, 11,000 members of the public talked to by over 50 local health watch, and they'd visited 550 different primary care services in order to support the work, and we were able to pull all of that together and some research that we've done with the public about the future of primary care to make significantly more than the sum of the parts. And it is, very far from the anecdotal kind of the fear that Health Watch would only be about anecdote and those who speak loudest. I mean, a lot of the work that Local Health Watch have done has been very focused on groups of the population who would otherwise not have a voice. So people with disabilities, people with hearing problems, people with language difficulties. They've gone out there and made it their business to talk particularly to those people. So I just kind of want to say I think I was very proud actually to be able to give evidence on the basis of it last week, and I think it's a good exposition of what Health Watch has become. So I encourage other people to read it.
Last question from Kay.
Firstly, just to thank you, Anna, for your contribution as the inaugural chair of Health Watch England and a member of the CQC board. I think you've kind of managed the interface of the two. You've managed to kind of maintain the, if you like, the integrity and the independence of Health Watch, as well as making a full contribution as a board member. And it was always going to be difficult, but I think you've done it very well. And I also think that you leave Health Watch England and Local Health Watch in a very good sort of solid place to go forward. My question, and you have kind of touched on this, is just thinking, what your reflections are on having been the chair for, is it 4 years or 5 or 4, 3.5, 2? What reflections, any other reflections you have as the outgoing chair of Health Watch? What you've learned, what you think might be challenges for the future, aside from what you've already touched on today. So,
Okay, I think these are very important questions, but we were rather looking to this afternoon's meeting to have a chance to have a debrief from Anna on these issues. So if it's okay with you, we could leave it to this afternoon, because these are very important questions, but I think this afternoon gives Anna a chance to speak absolutely freely about them. So this brings this part of the meeting to a close. The only other business, I think, is whether our the members of the public who are here have any questions. Would you like to sit in the...
I'm David Hogarth. I'm from Neighbour Care, St John's Wood and Maida Vale. Very often I've come here talking about a particular problem with the caring domain, in particular in the reinspection of care homes. The fact that very often you find that 4 domains are inadequate or requiring improvement, and then rather suspiciously you find that the caring domain is classified as good. And this time I wanted to say something slightly the other way around. I went to visit somebody in the London suburbs recently who'd just been put in a care home, and I wanted to see how she was getting on. I read up the recent report, and everything was wrong. Either it was requiring improvement or it was inadequate. So I went down there sort of bristling, expecting to find something really awful. And I talked to her, and the first thing she said is, I want to get out of this place. And so I said, oh, yes, and I suppose, I more or less put the question in her mouth, I suppose the staff are not very nice. Oh, no, she said, the staff are very, very nice, which indeed you had said in your report. But I never actually found out why she wanted to get out. I think basically because she was an independent person and didn't like being in care homes. But it wasn't the staff. So then I went and looked at the report in more detail, the caring part of the report. And I have to say that, you know, it seemed to me you said that they required improvement. 3 people had been given their porridge in a glass instead of a bowl. There was no choice of jam or marmalade. Well, I don't have that at home either. Some people had protective aprons put on them without being asked, but maybe they had been asked sometime before. The reason I think, in fact, why you got this, gave this requiring improvement was that they made the mistake of leaving a door open and the man inside had only the wrong half of his pyjamas on. So that, I don't think that is what the public means by caring. I'm going to be going into hospital myself in the next 3 months, and I want, obviously, that my knee shall be replaced properly. I don't want to get MRSA or C. diff, but next to that, I want kindness and compassion. I want them to come when I need to urinate, and I want them to laugh at the feeble jokes that I will make. Those are the things that really matter to me, and that's what I think the public really means by caring. But with the methods you are using at the moment, you're not finding out that sort of thing. You're finding out these sort of things, which are of some importance, some of them, but they're not what the public really wants. And I go back to the old thing. I do not think that without encouraging surveillance, however much we may dislike surveillance, without in doing that, you are not fulfilling that. And I was very pleased to hear Andrea talking about integrity before, but I don't think you can show integrity about caring unless you are really telling the public, you're really defining the word caring in the same way as the public does, which is compassion and kindness. So that is what I have to say.
Andrea, just a very quick response, please.
Two things in response. The way that we developed both the questions that we ask when we ask whether a service is caring or not, and also the characteristics of caring, we did, of course, do that in consultation with members of the public, as well as people who speak on behalf of people using services and their carers and relatives. And so I think that we did do quite a lot to make sure that the questions that we are asking are indeed the questions that people want us to ask about those services. And the second thing to say is that asking the question about whether a service is caring is all about are people treated with dignity and respect? Is there kindness? Is there compassion? Are people kind of responded to in the way that they want to be responded to? And I think that one of the key issues for us around caring is understanding how the staff do that and how they treat people with dignity and respect. And it would not be just an isolated incident that would indicate that something requires improvement. Our inspectors would have looked at the picture and the round to actually come to that judgment, and that would be the same across adult social care and the hospital's directorate, as well as primary medical services, I am sure.
I think, Mike, if you're happy with that, I think Mr. Hogarth, I'm sure Mike would be really interested to hear how, well, first of all, I'm sure the whole board hopes that everything goes well with the knee replacement. And, sorry?
And the jokes.
Well, yes, the joke's perhaps slightly less important than the knee, but it would be very interesting at the next meeting you come to well, certainly before that meeting, for you to give feedback to Mike on how it's gone. I think that will be very valuable. So thank you very much, and as I say, I hope all goes well. Any other?
Thank you for your good wishes.
Thank you, Chairman. Robin Pike, Hertfordshire Health Watch. 2 quick questions, if I may. The first concerns dentistry and the dental inspections. I have read the report that is attached to the agenda items. I was a little disappointed, perhaps, to read the balance between the interests of the dental profession and the interests of the patient, and a cursory glance at reviews of dental practices will show that many patients are not satisfied with their dental practice. They don't find it responsive or effective. And some patients are left in great pain for days on end because they can't get an appointment to see an NHS dentist. The out-of-hours provision is rather minimal, and patients in some cases are forced to pay into the private sector because they can't access NHS treatment. When are dental practices likely to be rated in the same way that hospitals, care homes, GP practices, ambulance trusts and other providers rated?
Steve.
Thank you. We've discussed dentistry at the board on a number of occasions, and we inspect 10% of dentists every year on a risk-based approach, and we work very, very closely with the General Dental Council and NHS England. In fact, we've set up a regulatory board across the organisations to share information to help us with that risk-based approach, because data is not as forthcoming, if you like, compared with hospitals or even GPs. We've made a decision consciously here not to rate dentistry for a number of reasons, but we will respond reactively if we hear of complaints, or if NHS England is picking things up through the contracting system. We will go into dentists, and the inspections are very thorough. And I don't know if you've read any of the reports, but the reports are very, very clear. But there is no current appetite for rating dentists, unlike GPs. General practice is much more complex a system than dentistry, but I take all of your points about access to NHS dentistry. That's an issue predominantly for the Commissioner and for NHS England.
I think you mentioned you had another question.
The question concerns the inspection of duty of candour. Dame Julia Miller recently commented that patient complaints within the NHS are often met with a wall of silence. And I wonder how, in practical terms, duty of candour is currently being inspected across the three domains, particularly actually in general practice.
Steve.
Well, hospitals started first on duty of candour, and we've started to incorporate that into what we're doing. And clearly, as we move the model forward, we will be hearing how that's going and how we take it forward in more detail.
Mike.
We always inspect for duty of candour in all our comprehensive inspections, and we would on any focused inspection if we thought it was a problem, if anything had been drawn to our attention. We do this alongside our inspection of how well incidents are being reported, and whether they are then being investigated and whether they are being learned from. And what we're now doing is to look at a sample of incidents. We can't look at all of them, but to see if those that are rated as being of moderate severity or greater, whether there is evidence that the patient or the family have been involved and dealt with appropriately. And we also look at a sample of reports that have been rated as either no harm or low harm to make sure that they have been appropriately reported that way. So I think we are, and we also ask staff whether they are aware of what the duty of candour means, and so that they would know that that was what they should do.
Thank you. Are there any other questions from the floor? Our last public board meeting of the year to a close. So we're going to break now. Before we restart, the NEDs are going to have a short session with David, really on the role of NEDs, and then we'll restart effectively just after 11. So if we can have a quick break for coffee and be back here in 5 minutes.